Hi, Darwin.
Hi, Bob. How are you?
I'm doing okay. How are you?
Very well, thanks.
Let me introduce us. I'm Robert Wright of Blogging Heads TV. You are Darwin Labarthe, and I think you're in Blanco, Texas, of all places at the moment. Is that right?
That's correct.
And Blanco is how they pronounce it down there, right? Notwithstanding the actual Spanish pronunciation.
Notwithstanding, that's pretty much standard Texas practice, is to murder the Spanish and use an anglicized pronunciation that the Spanish would not recognize or honor.
Uh-huh. Well, as long as it's working for you, we'll leave that intact. Tell us a little about yourself. I mean, you're a proponent of a concept called positive cardiovascular health, which we're going to talk about.
Correct.
And I hope we're gonna be able to make sense of what I'm holding in my hands, which is a lab report I got only this week from my annual checkup, which has my cholesterol level and some things like that. I hope you're going to be able to enlighten us all as to the true meaning of things.
We'll do our best.
Okay, but first, why don't you tell us a little about yourself?
I'm Darwin Labarthe. I'm a professor of preventive medicine in the Department of Preventive Medicine at Northwestern's Feinberg School of Medicine. I have been appointed there since early August after retiring from the Centers for Disease Control and Prevention, or CDC, in Atlanta, where I was director of our Division for Heart Disease and Stroke Prevention over the past several years. I was formerly in academia in the University of Texas School of Public Health in Houston, that for most of 30 years, except for a brief sojourn of about 4 years at Mayo Clinic in Rochester, Minnesota.
Okay. Well, you sound eminently qualified to tell me what my cholesterol level means. Before you do that, what about this concept of positive cardiovascular health? What exactly does that mean? And is that a kind of a way of thinking that you are an advocate of, or is it a way of thinking that is already taking root and we just have not been calling it by this name?
Well, I would say I am an advocate for the exploration of this area, which we have the good fortune to do with support from the Robert Wood Johnson Foundation's pioneering portfolio. It's an area which has become a focal point of a development taking place over the past several years, beginning with positive psychology around the beginning of the century, moving forward from positive psychology to a more generalized view of positive health, and a more particular version of positive health with respect to cardiovascular disease. Why cardiovascular disease? Because it is the commonest affliction in our society as a cause of death, a major cause of disability, health disparities within our population, huge contributor to healthcare costs. And so if there is something about positive health that can have specific implications for reducing these burdens of cardiovascular disease, this would truly be a winner for public health, for the nation, and have a major impact on our health economy.
Okay, let me stop you there and ask you, when I think of positive psychology, I think of the idea that psychology should do more than just kind of fix maladies, more than identify existing pathologies and fix them, but should also take people who have no particular pathologies and make their psychological life better. That's one of the things, at least, that it connotes. To what extent is that an analog of what you're doing with positive cardiovascular? Is it basically kind of the same idea transplanted to a context of your heart?
Sure, Bob. I would say that this is a particular instance of what you've just described in a more generic form as positive health. The notion is that we all have certain attributes along a scale from positive to negative, relating to our emotions, our attitudes, a variety of psychological states, quite apart from the biological or functional attributes that we carry along. If we are able to identify clearly and rigorously those psychological attributes that have the most positive effects on our health, in the cardiovascular area, this would translate into a reduced likelihood of having a heart attack or stroke, the improved survival or recovery from that event when it should occur, better quality of life, lower lifetime healthcare expenditures. And so what positive cardiovascular health is doing is taking the generic approach of positive health and trying to translate it or investigate its translation into this particularly prominent area of health concern for many of us as individuals and for our society and community as a whole.
So what is it, and another term that's been in currency lately is wellness, right? There's a place out here near me called the Wellness Fitness. It's a fitness center, but it's a wellness fitness center, and it actually has a relationship to the hospital, and it has actually good, physical therapists, and I think, they talk about, is that related to positive health?
I think it's related in the sense that the broadest purposes of wellness, which are to encourage good health and well-being, are a part of positive health. But I think positive health goes somewhat further. I described a moment ago the potential impact of positive cardiovascular health, not only in reducing the risk of having a heart attack or stroke, but improving the outcome if this should occur, and assuring a longer, healthier life beyond. This, I think, goes further than wellness, which tends in some instances to become more an ideological point of view than it does a rigorous scientific discipline, which is what positive health is becoming.
By ideological, you mean what? Well, what's the ideology of the wellness movement?
Well, if you were to click on wellness on Google, you would see a large number of zeros behind the number of hits that had just been contacted in a millisecond. And many of those would have to do with commercial products, with slogans about wellness that are perhaps fundamentally in spirit, in the interest of improving health, but are not in themselves reflective of a science and a rigorous science such as positive health is becoming.
So wellness has become a commercial slogan that
very
may
often,
or may not,
very often
correspond to you. Yeah. Okay. So good. And so a part of this positive cardiovascular health is the idea of preventing bad things from happening, and I'm sure a number of people my age are interested in the subject of how you prevent bad things from happening to your heart. I want to start out with, I guess, a kind of selfish question, because again, it does come from the the lab report that I just got. And if you want, I will disclose my actual cholesterol numbers to you.
Okay.
And you can tell me how things bode for me. But first, I have a question, which is, everywhere online I read about cholesterol. When I try to make sense of this, okay, I've got my total cholesterol level, which is kind of bad, the worst it's ever been, actually, which is 220. On the other hand, the ratio of total to HDL, the good kind of cholesterol, 220 to 66 is only a little more than 3, I guess, which is good, right? And then when I did my ratio of HDL to LDL, that was good by standard reckoning. But what puzzles me, and my total is clearly kind of bad, 220 is higher than optimal. But what puzzles me is that I keep hearing that, well, there's disagreement over which of these indicators to pay attention to. I would think this would be the most straightforward problem in the history of statistics, right? We have a huge amount of data about people who have had heart attacks and people who haven't, and about what their HDL and LDL and total cholesterol was. Shouldn't it be a simple matter to determine what the most powerful predictor is in terms of cholesterol?
Well, it's simple in one respect, and that is that the guidelines that indicate how doctors should measure and evaluate and recommend action on your cholesterol is fairly simple and straightforward, and it's based on the LDL cholesterol. I didn't hear a number from you, Bob, about your LDL, but it's probably there on the sheet.
It's pretty bad. It's 144.
I'm sorry?
144.
Yeah, well, the enthusiasts about reducing LDL cholesterol are talking now about levels below 70. So that would suggest 70. That you have quite a way to go. True,
way,
there
man.
are other measures, and some that you have not mentioned, that are part of the current scientific enterprise. They're part of the discussion. Is one of these a better predictor than another? Is one of them more sensitive than another? How do they line up side by side as predictors? How do they relate to what can actually be measured conveniently in the clinic and potentially modified through therapy? A lot of interest in drugs that may raise the HDL cholesterol, the good cholesterol, as well as lowering the bad, the LDL cholesterol. And this is the way science works. I mean, there's a lot going on. It's an area of considerable importance.
Sure.
So,
but what I'm asking is, I mean, it really seems to me it should be a straightforward problem. I took statistics in college. If you have, 3 different variables associated with each person, okay, total cholesterol, ratio of total to good, and ratio of good to bad, if you've got all of this at your disposal, and you know who had the heart attacks and who didn't, I really don't understand why they can't tell us which is the strongest predictor.
Let me ask you a question, Bob.
Yeah.
What was it that led you to have your cholesterol measured in the first place?
My father did have heart trouble, but it was my annual checkup. I mean, they just take blood every once in a while and do a whole bunch of these things,
Mm-hmm.
This is 220 is the worst the total has ever been. So I do have a history of, but on the other hand, my father was kind of totally the opposite of the optimal lifestyle.
Sure.
And I'm not. But anyway, okay. So
well,
we should
just one last question to follow up because it
Sure.
links to our discussion about positive cardiovascular health. What advice were you given to deal with your cholesterol?
My doctor is pretty laissez-faire. I mean, my previous doctor said I was right on the cusp of recommending medication. They also, in last blood test, they did this inflammation index thing.
Yeah.
That's another predictor. And I was kind of off the charts good on that. I'm very low inflammation, I'm happy to report. To everyone who's been wondering about my inflammation status. And I exercise a lot and stuff, and I'm sure that goes into the calculus. I'll tell you, my previous doctor, this is maybe a little of interest to people that they have this calculation they can do. The doctor I had previously, before he became one of these boutique doctors who charges too much, he did this. He plugged in the inflammation index, the cholesterol, everything he knew about me into an equation, and the numbers he got were something like, you've got a 9% chance of having a heart attack within the next 10 years, and if you take cholesterol medication, you can lower that by 1 percentage point to 8. It was something like that. 9 to 8, 10 to 8, 10 to 9, something like that. And I just thought, no thanks. Okay?
Yeah. Well, my question was leading up to the issue of what you experience when you get your report of your cholesterol and how you should move forward. Certainly a part of any response to a cholesterol level of concern would be advice about improving your diet and your physical activity, possibly some weight loss depending on where you are. My recollection is you're unlikely to have a weight problem, but the balance between your diet and your physical activity could be. And beyond that, the question, how confident you might be that you could actually make such changes, sustain them over time, and actually reduce your risk. Take charge. What positive cardiovascular health would say in this situation is that there is the potential for those who believe in the ability to regulate their lives, those who are optimistic about the outcome, to be more successful than others in making these changes. Possibly you could manage without medication to lower your cholesterol to a target level that would be much more satisfactory. So this is just one little piece of the way positive cardiovascular health could intervene in the doctor's office. And as positive cardiovascular health becomes developed, it may in fact have the effect of turning medicine on its ear and making the first recommendations about how you are thinking about your health, how you take charge of your health, and how you then incorporate some of the changes that would be medically recommended.
I actually, I think I've observed that I actually can lower my cholesterol level when I'm a really good boy, but that means not eating any dark chocolate, and I'm just not sure that that's a trade-off I'm willing to make.
Well, there is an approach, called the poly meal, which was a, no pun intended, tongue-in-cheek response to the poly pill idea. And don't worry, dark chocolate was a part of the hypothetical poly meal that would serve to reduce your risk.
Yeah, but it doesn't reduce LDL, right? I think how does dark chocolate reduce your risk exactly? Do they know
I think the mechanism is not at all clear, and those who enjoy dark chocolate aren't probing too closely.
No, as long as you tell me it's good for me, I'm really not going to lie awake at night wondering why.
Right.
I'll just follow your orders, which is to eat even more than I'm eating. Thank you for that, and you can go now, Darwin. That's all I really came here for. No, actually, I wanted to ask you, in terms of people other than me, in terms of people you've actually encountered in the real world, what are the most common things that people are failing to do that they could do to improve their cardiovascular health?
Well, that's a very important question, and there are different answers for different people in different stages of life. And let me begin with childhood, where life begins and where the life course takes off. What we've learned in very recent years as we begin to understand the benefit through life of being at low risk for cardiovascular disease, that is low cholesterol, low blood pressure, low blood sugar, no smoking. Low risk is highly prevalent in childhood and gradually dissipates through adolescence and into early adulthood. And so if we're going to talk about what you can do to improve your chances of avoiding a heart attack or stroke, beginning in childhood, improving diet, physical activity to maintain good health are very important strategies. And we are to a large extent allowing the good health of our children to slip away unattended. By the time one is an early adult, a lot has changed. More independence in habits of diet, physical activity, and so on. It's important here to continue to watch these basic factors, the cholesterol, the blood pressure, avoid smoking and smoking people, maintain body weight into and through early adulthood, such that one could potentially reach age 50 at low risk. And there's a fascinating body of research that has evolved over the past decade that says that those who maintain low risk to age 50 in terms of these same factors have a much reduced risk of having a heart attack or stroke in later adult years. They live longer. Their healthcare expenditures are less. And in general, their health is far better than those who have already developed these major risk factors by age 50. So by age 50, the stage is set for high risk if the risk factors are present, but very low risk if they are not. And again, from age 50 forward, if risk is low, it can be maintained through particularly habits of diet and physical activity, again, avoidance of tobacco and tobacco smoke. These are factors that continue to be relevant through the end of life. And while it's true that factors such as high blood pressure are very common among older people, for those who have not developed high blood pressure, it remains something that can still be prevented. So one of the large factors people are less aware of than we would wish is the very widespread effect of high salt intake on blood pressure across the population. This begins in childhood and continues throughout life. That's something we could discuss at length if you're interested.
Yeah, I want to, but
certainly want to call attention to it.
Yeah, I want to talk about salt because it confuses me too. But one thing, one interpretation of what you're saying is that, like, at my age, I mean, the stage is set, as you put it. And are you saying there's not that much I can do? I should have started sooner, so I might as well relax and have a good time and eat even more dark chocolate. I would kind of like that to be the takeaway lesson here.
Well, the takeaway lesson is that there is the potential to improve either by treating these conditions if they are present, taking medication for blood pressure and cholesterol if needed, or taking charge of them through improved diet, physical activity, sleep habits, and so on. And so I would only want to say that the opportunity for prevention is something that continues through life. And this is one of the aspects of positive cardiovascular health that is, I think, going to become an established part of medical thinking. That throughout the life course, there are opportunities for people to strengthen their resolve, to strengthen their confidence, to strengthen their optimism, and their ability to actually bring about effective control over these factors. So this is, I think, a major contribution that positive cardiovascular health can be expected to make.
Okay. Well, I'm in some ways disappointed to hear that I shouldn't adopt an attitude of hedonistic resignation to my fate. But I'll do whatever you say and try to improve. Now, about this salt thing, there I'm confused. And this is, I think one reason people are sometimes a little skeptical of recommendations that come out of science in general. There sometimes is vacillation, right? It seems to me I recall in my youth, salt being a known risk factor for blood pressure and being bad. And then I recall a brief golden era when I think I was reading that you could eat all the salt wasn't so bad after all. Am I imagining that? And now I think they're saying it's bad again, but am I imagining this golden era when salt was okay?
I think you are, actually, Bob. I think you may have tuned into you may have tuned into a minor current that appealed to you and that attracted you. I'm not making any character judgment here, but I think it may be that you overlooked the continuing concern, continuing recommendations, continuing pronouncements, if you will, by the majority of the scientific community and the medical community and the public health community, that it's time to reduce the salt intake of our food, salt content of our food, and the intake of the foods that contain the major part of the salt in our diet.
But here's the problem.
We simply are consuming too much, and the Institute of Medicine reported in their assessment a little over a year ago that the current intake of sodium in the U.S. population is, in their terms, simply not safe. And I think this leads to a cue to both personal and medical and public health action to respond. There are immense implications for the burden of cardiovascular disease and healthcare costs.
Mm-hmm. Just out of curiosity, I'm looking at my sodium serum level or whatever in this report. If I'm eating too much salt, would that be reflected in the sodium level in my blood, or is that not a good indicator?
That's not the indicator that will tell you about your salt intake and whether it is excessive or not. Somewhat inconveniently, the place to find that out is in the urine, and ideally with a 24-hour collection.
No, we don't have
that
we
will
don't
be
have
the
time
best
for that.
indicator of the amount of sodium that you're consuming on a day-to-day basis.
No, I'm afraid we only have a short time left, so we don't have time for that, Darwin. But they did actually. Oh, actually, I have that. They did that, I think, but I just don't know how to interpret that. These are just cryptic three-letter things like WBCLYMO. We won't go into that. But on the salt thing, so there is a chemical index of it. But anyway, the main problem is it leads to high blood pressure, right?
High blood pressure, yes. It's also related to some forms of cancer. So it's not only a cardiovascular problem, but high blood pressure is certainly the major impact that it has that is of public health and medical concern.
Okay. So cholesterol, salt. Salt is a lot easier to manage in a way than cholesterol, because cholesterol is not a simple matter of how much cholesterol there is in the food you imbibe. Of course, it's cholesterol is it's way more complicated. What else? By the way, does exercise work partly by improving your cholesterol stats? Does it have that
works
effect?
in several ways, and it probably has multiple channels of action that affect cholesterol. One very direct one is that it raises the HDL or good cholesterol, which helps to take care of some of the accumulation of the bad cholesterol. But it's also true that people who exercise enough to have that benefit are very often people who are more health conscious, more optimistic about their lives and their ability to improve their health, and their dietary patterns go along with that. They're not likely smokers, they're not likely excessive consumers of alcohol, and these factors all go together as kind of a behavioral package, if you will.
But alcohol, there's another problem I have. I don't drink at all. Wouldn't I be better off if I had like just one glass of red wine a night or something? I mean, statistically, isn't that better than not drinking at all?
Whether you would, Bob, or not is a difficult matter to judge. And no one, to my knowledge, in the medical field has advocated recommending use of alcohol to those who do not consume it regularly. The advice is that if you look at the population as a whole, there's kind of a U-shaped curve that says that people who drink to excess have very high risks of a lot of bad things, including heart attacks and strokes. People who drink not at all have a somewhat higher than the minimum risk of these events, nowhere near as high as those who consume in excess. And so there is a low point on the curve that's at a sometimes called moderate level of drinking. Now, what you think is moderate and what I think is moderate and what the guy serving drinks at the bar thinks is moderate leaves that term a little vague and unclear. But the notion that a small amount of alcohol appears to benefit those who customarily drink a little bit of alcohol is a notion that the observational evidence clearly supports. I don't know of a good experiment over a period of years to say that drinking more or less by a random assignment would have a known effect on your risk of cardiovascular disease or other outcomes.
And that's important.
And that's an experiment that won't be done. So we're kind of stuck with the information we have.
So it could just be that people who by nature find it easy to be moderate drinkers are the kinds of people who in other aspects of their life do things that make them not susceptible to heart disease or have characteristics that make them not susceptible. I mean, it seems the reason. They're probably less mercurial. They're probably, right? I mean, so for all we know, that's interesting that there have never been controlled studies. I mean, for all we know, the alcohol per se is not responsible for this statistical effect.
Bob, I agree with you completely, and I have held out for years on the point that no one has proved that increasing your alcohol consumption is protective against heart disease, or that heart disease is caused by alcohol deficiency. So I'm right on with you on that point.
Yeah. Again, you've said something that slightly disappoints me. I would be happy for you to tell me that I should start drinking, I think, but you have not told me that. But that leads to this question. I use the word mercurial. There's another part of this puzzle that's long fascinated me, which is the role of personality characteristics in heart disease. Of course, the famous term here is type A. Dr. I think Friedman, I forget his first name, popularized this idea that people who had kind of intense personalities were susceptible to heart disease. I think subsequently there was some refinement by researchers of what really the variable is in personality that's most closely correlated with heart disease. But in any event, I assume it is still believed that there is some significant causal relationship between certain types of personality and heart disease. Is that right?
Yeah. This was the work of Rosenman and Friedman that identified this so-called type A behavior pattern. It was investigated mainly through one long-term prospective study, the Western Collaborative Group Study, so-called. It was not easily replicated by other investigators, but a sort of definitive study was undertaken within the so-called Mr. Fit study, the Multiple Risk Factor Intervention Trial, MRFIT, in which participants, and these were men with increased risk of cardiovascular disease, were enrolled, followed for years, in which it was possible to classify them with Rosenman's approval of the method in terms of presence or absence of type A or type B personality. It turned out that type B did less well than type A. And this was largely the death knell of the type A hypothesis in itself. But there is a kernel within it that has been elusive, has been chased for years by other investigators, and may have an answer in terms of hostility or outbursts of rage, which more recent studies have shown to be closely associated with the precipitation of a heart attack. So I think the end of the story is that type A was interesting. It was upheld tenaciously by its initial investigators, did not hold up, but it has appeared that there is something on the negative side of personality that is probably causally related to precipitating heart attacks and possibly strokes. Yeah. So just to link this back to our earlier conversation about positive cardiovascular health, positive cardiovascular health is about just the opposite situation. That is the positive attributes that people carry and experience and can build upon to maintain a low risk of these events. So type A was the other extreme. Positive health is the opportunity to improve the quality of our lives through strengthening the positive assets that we have.
Yeah, I actually I edited a piece long ago, a couple decades ago, by one of the researchers who was refining the type A typology, and he used the word cynicism. He did use the word hostility, but he talked about a cynical attitude in the sense of kind of being suspicious of everyone, and thus being very easily drawn into a hostile kind of frame of mind toward people. And I actually remember we did a cover story. It was his cover story at the Sciences magazine. Gives something that caution, cynicism may be hazardous to your health. So some element of that remains plausible, it sounds like.
Well, yes, and I don't recall encountering cynicism specifically, but as Roseman and Friedman described their concept of the type A personality, that would not be far-fetched as an additional characteristic of those they classified as type A.
Yeah. Okay, now, you, I think, had some ideas about a connection between positive health and the Affordable Care Act, I think whose status is still in doubt. I think it's still being challenged in the courts. But in any event, this is President Obama's health care legislation, right?
Right.
What's your take on that?
Well, what I would want to call attention to in this connection, and it is important for public health and for prevention, and potentially in a very specific way for positive cardiovascular health, is one section or one title within the Affordable Care Act, which is Title IV, and it addresses clinical preventive services and community and public health. One reason this is important is because it sets out clearly, as a matter of law, how it will be decided what kinds of health interventions should be reimbursable, should be free of out-of-pocket cost to patients, and should become part of health policy. Now, we're interested in positive cardiovascular health, in seeing how far the science will take us toward developing meaningful interventions that would be part of clinical practice or could be part of public health policy, community health initiatives, and the like. If we are to meet the bar that is set under the law for approvable interventions, what we need to do is to design and implement a body of research that will meet the standards of two organizations. One is the United States Preventive Services Task Force, or USPSTF, that makes clinical recommendations. The other is the Task Force on Community Preventive Services that has a corresponding role for public health policy. So as we, in our group, dealing with positive cardiovascular health, think about next steps, we want to build on a substantial body of literature that has been extensively and very insightfully reviewed to establish that this is plausible, that positive cardiovascular health can be a reality, and take it the next step through the research that would be needed to meet the goals and the requirements of these two bodies. And so that's where we're going right now. But all of this depends, of course, on the sustainability of the Affordable Care Act, and I'd point again particularly to Title IV, provisions that have to do with how people can access their health care and what kind of out-of-pocket costs they can be expected to pay or may avoid, and what are the policies for developing community and public health activity. So the law is very important in this respect, and with due respect to the media, I'd say it's something that has been completely off the table and not a part of the public discourse about the Affordable Care Act or the health reform law. So these things are closely related, and it will be very important to do what can be done over the months and perhaps years ahead to assure that these key provisions are sustained in order to promote positive health broadly. And positive cardiovascular health in particular. So,
kind of relatedly, the when it comes to deciding what kind of preventive measures or preventive therapies or preventive consultations should be subsidized by the government, can you kind of count on insurance companies to actually be on your side of this argument? When I mean, do they lobby? I mean, of course, they want to. They're looking at the bottom line, and if if an intervention now or a consultation now can reduce the chances of a costly intervention much later, they're in favor of it. Do they tend to be your ally in these arguments?
Well, they can be, Bob, and how they align depends to a great degree on which parts of the law are under discussion and on the perspectives of different insurers and providers of care. What I would say is that there is a substantial body of evidence in systems which are closed. That is, the payer for preventive services is also the payer for clinical care when bad things happen. In those settings, it's been possible to show that an organized program of preventive services, which includes behavioral counseling, support for behavioral change, as well as medication when needed, pay several times over in terms of a return on investment. This is something that can and should be a major interest of the insurance industry. I think we see in HMOs, for example, where there is a capitation and a large subscriber panel, an increasing investment in prevention in order to reduce downstream costs. A heart attack that doesn't occur costs nothing. A stroke that doesn't occur costs nothing. And these events are preventable. In fact, the federal government has just launched mid-September a new initiative called the Million Hearts Initiative. This is the creature of Tom Frieden, director of CDC, who with Don Berwick at CMS has launched a Million Hearts campaign with the idea of preventing 1 million heart attacks and strokes in the first half of this decade. How? By implementing these provisions of the Affordable Care Act, by making aspirin available to those who should have it, blood pressure and cholesterol control effective for those who need it, providing cessation advice and support for those who are trying to quit smoking. Now, these are things that have some cost to insurers, but the payoff is huge. And so, is the insurance industry on the side of all aspects of the Affordable Care Act? Perhaps not, or not yet. But it certainly is hoped that their support will be rallied for these provisions that have so much to contribute to improving the health of the U.S. population.
Okay. All right. Well, thank you for this, Darwin. This has been a fascinating briefing. And the takeaways for me, I gather, are I can continue to eat dark chocolate, you're saying, but I should start taking cholesterol medication. I should reduce my salt intake, which I have to admit is extensive because I like sunflower seeds. And I should not start drinking. That is your advice to me as I understand it.
I'm saying be well by all the means available to you, and believe that by doing so you will gain in the long run. You will be a happier, healthier, longer life person, and we'll all be grateful to you for that.
Okay, and in return, I say to you, Darwin Labarthe, be well yourself, and thanks again for this.
Thank you, Bob. Take care.
Okay, bye-bye.